Disturbance.
Yes, sir. So we are live now. Very good evening, everyone. I am Arpita from the IGCP group. The topic that we are going to cover today is prostate cancer, current trends and management. And yes, we have someone very eminent from the field to ensure us that the topic is rightly discussed. None other than Dr. Raghunath S.K. Sir. It's an honor for me, sir, to welcome you to our platform and to introduce sir to everyone. Sir has done MS in General Surgery, DNB Urology, Fellowship in Uro-Oncology.
Hello? I can't hear you, madam.
Sorry, sir, went on mute. Yeah, sir has done MS in General Surgery, DNB Urology, Fellowship in Uro-Oncology, a fellowship in laparoscopic urologic and robotic surgery, and fellowship in molecular oncology of prostate cancer, Washington, D.C. He is the director of urological oncology and robotic surgery at the 8th CG Cancer Hospital and also vice president of GPCF Bangalore. With this introduction, I will now request sir to please start with his presentation. Over to you, sir.
Thank you, madam. A very good evening to all of you. Uh, it's a pleasure and honor for me to be here on this platform and reaching out to you all. My special interest is prostate cancer. I have done my general surgery and DNB urology from Nadiad and did my fellowship in uro-oncology from Rajiv Gandhi Cancer Institute. Because of my interest in urological oncology and work related to prostate cancer, I did my fellowship in molecular oncology of prostate cancer from Washington, D.C., from Center for Prostate Disease Research. And from last 18 years, I've been doing only urological oncology and robotic surgery. And ours is the first center to establish urological oncology center for the first time in South India. And almost 70% of our work, whatever we do, is related to prostate cancer. I'm right now working at HCG Cancer Hospital. It has 21 cancer hospitals across India. The flagship unit is in Bangalore, and I am heading urological oncology and robotic surgery department. Also, I would like to tell you something about Global Prostate Cancer Foundation. Uh, this foundation is an NGO. I am the vice president of this organization. A lot of patients are part of this. Cancer survivors are part of this. They are creating awareness about prostate cancer. So far, we have created awareness for more than 1.3 lakh families so that uh, prostate cancer can be detected early. And if you detect early, it is possible to cure 100%. So with that introduction, I would like to move forward. So, all of you know, I would like to just pay attention for all these slides, first initial three, four slides, so that you can understand what is cancer, the basics of cancer. Can cancer be prevented? How cancer can be diagnosed? What does cancer stage means? Generally, we say stage one, two, three, four. What is the meaning of that? And what are the risk factors? How cancer can spread? How can we prevent? All those things can be discussed. Normal cells, if 10 cells dies, automatically replaced by 10 cells. So it won't get replaced by 100 cells. So because there is a pattern, there is a healing process, and it has a perfect healing process happens because of our genetic control. We have a DNA. DNA does all this, repair work. Whatever is required, only it will do that much. But what will happen if the DNA damage happens, or we call it as mutations? The cells will continue to grow without any control. So when more number of cells are there, uncontrolled growth is there, this piling up of cells happens, that becomes a tumor. In a layman's terminology, I'm just telling you to understand this in a best possible way. So, as you know, tumors can be of benign tumors and malignant tumors. We call it as cancer when it is a malignant tumor. So cancer and malignancies both are one and the same. So benign tumors are not cancers. They generally can arise from any organ, but generally it does not spread to other parts of the body. It can grow locally. It can probably push the adjacent structures. It can increase in size, but generally it does not spread or metastasize to other parts of the body. Whereas malignant tumors or cancers, it does not stay at that particular site. It spreads to other parts of the body, commonly to lung, liver, bone, and other organs. So, what causes cancer? Why do we get cancer? To tell you, elephants do not get cancer because elephants has more than 20 pairs of P53 gene. P53 gene uh, controls and checks the development of cancer. Even if any cancer is developed in the elephant, so that will be killed immediately. So it has a perfect control. The immune system regulates all these things. Unfortunately, we have only one copy of that. So if that is damaged, we can probably get any cancer. So whenever mutation in this tumor suppressor genes are there, we can develop cancer. Apart from that, this mutation can happen in two ways. One is by genetic, we inherit those genes from our parents, that is one. The other one is second hit from environmental factors. So, first one is genetic or familial, where we don't have any control over that. We are going to inherit that from our parents, so we don't have any control. What we have control over is the second hit. That means the way we live or the what we are exposed to in the environment or the workplace. It could be radiation, it could be viruses, and the way we live. According to recent study, the pesticides use is very rampant. Without pesticides, we cannot grow any vegetables. And when we eat these vegetables, chance of getting cancers in general are very high. In India, right now, according to recent report, 12% of cancers are attributed to this pesticides use. So I urge strongly to avoid vegetables which are grown without pesticides. So you can grow your own vegetables or organic vegetables you can grow, or terrace gardening can be done to prevent all these cancers. Of course, tobacco use, diet, alcohol, and lack of exercise, these are all the factors where it can promote cancer. So what are the common risk factors? As I told you, the diet, which includes what we consume, and tobacco is most common. There are viral infections. Sexual practices are responsible for some of the cancers, particularly for penile cancer and cervical cancers. And alcohol, to some extent, it can also causes. It's labeled as level one carcinogen, alcohol. So it causes around 3 to 4% of cancers. So how the cancer is diagnosed? Whenever there is a abnormal growth, we take a biopsy. It could be FNAC, fine needle aspiration cytology, or true-cut biopsy. When it comes to prostate cancer, we always take true-cut biopsy, and it'll be sent to the lab. The expert pathologist will stain that, make it into a slides, and see under microscope. They diagnose it as whether cancer is there or not. It varies from type of cancers. In types of liquid malignancies is called blood cancers. They take the blood sample and send it for lab. In case of solid malignancies, we take the piece from the uh, tumor and we send it for biopsy. So you can ask me any questions. Please note down all the questions. I would like to answer all the questions at the end. So how does cancer spread from one side to another side? Generally, it spreads from adjacent organs. It can infiltrate. Like for example, in case of kidney tumor, it can infiltrate the adjacent organs like duodenum on the right side, or it can infiltrate the colon on both the sides. That is number one. So direct infiltration. Second one is lymphatic spread, and third one is blood-borne metastasis, where even prostate cancer can go to the bones through the blood, or liver, lung, or even to the brain. So coming to prostate cancer, what we spoke all this while is about in general about any cancer. Coming to prostate cancer. So prostate cancer, before understanding prostate cancer, I would like to tell you something about non-cancerous enlargement of the prostate. Is called benign prostatic hyperplasia or benign prostatic enlargement of the prostate. So I'm sure you all would have seen many patients suffering from benign enlargement of the prostate. And you would also see prostate cancers. The important thing to differentiate between these two is whether it's a malignant disease which is causing the symptom or benign enlargement of the prostate which is causing the symptom. That discrimination is very important to plan the treatment. So you all know prostate gland where it is situated. It is situated deep inside the pelvis, which is located just below the bladder. And you see, you can make out this is the bladder. Bladder is a pelvic organ, and below that is the prostate. Prostate is about 12 to 14 grams in size. The urine passes through this prostate, and semen also passes through this prostate. So we will tell you enlargement of this or cancer in this, what symptoms you get, because urine passes through this, there will be some symptoms related to urination. So you can also understand from this picture that it is very close to the rectum. You can make out it is very close to the rectum. So how do we feel the prostate which is deep inside the pelvis? By doing rectal examination. We insert our finger into the rectum and we can feel for the prostate whether it's firm, hard, regular, irregular, any disparity in the size of the prostate on right side and left side. So by doing this digital rectal examination and some tests, we can diagnose any diseases in the prostate. So I would like to briefly touch upon benign enlargement of the prostate so that you can understand the prostate cancer in a better way. Benign enlargement of the prostate is because of aging, like how we get gray hairs around 40, 50 years of age. We get the enlargement of the prostate around the same time because of subtle hormonal imbalance. Our testosterone levels will go down. Relatively, our estrogen levels will go up. Because of this, subtle changes, it's also called andropause. In women, we call it as menopause. In men, we call it as andropause because of the subtle changes in the hormonal milieu. So prostate starts enlarging. And this benign enlargement of the prostate is seen in almost 75 to 80% of men. You and me can also develop benign enlargement of the prostate after the age of, say, 50, 60 years. So what are the symptoms? You can understand from the left picture, you can see here, a normal prostate in younger individuals where urine can pass from the bladder through the prostate without any obstruction because this passage is open. Whenever the BPH or even prostate cancer happens, the enlargement of the prostate takes place. When enlargement happens, there will be a tough capsule. It cannot spread outside. It cannot enlarge outside. So what it causes? It causes compression inside. That causes obstruction to the, you can make out the urethra. This is called prostatic urethra. So prostatic urethra gets compressed. So patient will develop symptoms. What are those symptoms? Obviously, when it's compressing the prostatic urethra, it causes slow urinary stream. Patient may strain to pass urine. Because of the obstruction, he may put more pressure to pass urine. The first symptom to appear in this is night frequency. Generally, up to the age of 50 years, nobody will get up in the night, or generally, if they drink more water, they can develop maybe once or twice. After the age of 50 years, passing urine once or twice is normal. If frequency is more, probably we need to look into that. The hesitancy is another symptom, meaning to say, when you go to the restroom, the urine does not come immediately. You wait for some time. And before you could empty your bladder, others would have come and passed the urine and gone, but you still remain there because you take more time to initiate the stream. The other symptoms are urgency and urge incontinence. Of course, these are not directly related to the enlargement of the prostate. These are secondary to changes in the bladder. And sense of incomplete voiding. Because obstruction is there, bladder cannot apply too much of pressure to empty all the urine. So some amount of urine can left over in the bladder. It's called sense of incomplete voiding. So patient will pass urine, but at the end of urination, he will feel, no, some amount of urine is still there. I am unable to empty to completion. So that symptom can be there. Very rarely, whenever obstruction is there and residual urine is more, though they can develop urinary infection and other complications of obstruction. Uh, Sometimes we do see blood in the urine or retention of urine because of acute obstruction. So treatment for benign prostatic hyperplasia depends on the symptoms. If mild symptoms are there, generally we don't give any treatment, we observe. If moderate obstruction is there, we may give initially 5-alpha reductase inhibitors if the size of the prostate is more than 40 grams, or alpha blockers. You have many alpha blockers. You can give even combination of alpha blockers and dutasteride to reduce the size of the prostate and to open up the uh, prostatic urethra. In case the symptoms are severe or the symptoms are not reducing with the medications, then only we go for surgery. Open surgery we don't do for benign enlargement of the prostate. Generally, we go for TURP and a very common term, laser prostatectomy. There are different types of lasers. So basically, you are going to de-obstruct the system. You remove whatever the obstructed part of the prostate, the central part around the urethra, so that the passage can be big, passage can be made wider, so that patient can pass urine easily. After this TURP and laser prostatectomy, still the prostate will remain there. Prostate capsule will be there, peripheral zone of the prostate will remain there. Still, they can develop cancers in that prostate remnant. So, whenever they develop these symptoms, it's very important to discriminate these symptoms are because of prostate enlargement or prostate cancer. Because in both benign enlargement of the prostate and prostate cancer, the symptoms are almost same in the early stage. It causes compression of the prostatic urethra. It causes the same symptoms, urinary symptoms, with both benign and malignant enlargement. Unfortunately, even in India, we are diagnosing prostate cancer after doing TRP, which is wrong. Even before TRP, just by doing rectal examination, that is digital rectal examination and PSA, you can identify whether chance of having prostate cancer is there or not, because for prostate cancer, TRP is not the right treatment. So, with this understanding, let us move on to prostate cancer, which is very important for all of us, because prostate cancer is almost second commonest cancer amongst men, even in India, particularly in metros like Delhi, Bangalore, and Pune. And a given OPD, today we saw around 70 patients OPD. In that, 45 of them or 46 of them were prostate cancers. It's so common. And because we do only urological oncology, we get more patients. And when you take United States and European data, it is most commonly diagnosed cancer next to skin cancers. It is second leading cause of cancer deaths in American men. And 1 in 6 American men suffer from this prostate cancer. We don't have exact Indian data. Probably in Southeast Asian countries, 1 in 15 is the data, what data says. 1 in 15 men, not 1 in 6 as in America. In Bangalore, Pune, and Delhi, according to 2020 Globocan data, it is the second commonest cancer amongst men. So, who is at risk of developing prostate cancer? Commonly, this prostate cancer is seen in 6 to 7 decade. It is very uncommon to see under the age of 40 years. So that's why even the guidelines recommend PSA testing for men after the age of 50 years. But in case of family history, they are likely to develop prostate cancer early. So you have to start checking from the age of 40 years. The family history plays a major role because prostate cancer will have a genetic link. So we may inherit the genes from the parents, either from father or mother. So the risk of, familial risk of developing prostate cancer is slightly higher. If any of the family members are affected with this prostate cancer, either mother is having breast cancer or father is having prostate cancer, the next generation is likely to develop prostate cancer. The risk will be around 2 to 7 folds of developing prostate cancer. The risk can go higher if several relatives, like for example, father is suffering from prostate cancer, grandfather died of prostate cancer, mother is having breast cancers or any other cancers, uncle is having prostate cancer, then the risk will be even more and it can go up to 11 folds. So risk increases with not just family history of breast cancer or prostate cancer, even with ovarian cancer, family history of ovarian cancer, colon cancer, stomach and pancreatic cancer, the risk will be slightly higher. When it comes to diet also plays some role. Red meat is not good for prostate cancer. It increases the risk of developing prostate cancer. And diet rich in lycopenes and curcumin. Lycopenes are nothing but chemicals which are present in tomatoes. When you take raw tomato, this lycopene bioavailability for the body is very less. In a cooked tomatoes, lycopene's availability will be more. And curcumin is nothing but haldi or turmeric. That also, to some extent, decreases the incidence of prostate cancer. In every household, we use curcumin. Probably that could be one of the reasons why the risk of developing prostate cancer is relatively less in India compared to Caucasian population. There is one paper where they studied the sexual activity for almost 35 years. So increasing the frequency of sexual activity or even masturbation has some role to play in decreasing the risk of developing prostate cancer. So more frequency of sexual activity can reduce the risk of developing prostate cancer. But overall, if you say predominantly it's a genetic disease. It is very difficult to prevent prostate cancer just by controlling diet and your physical activity. There are so many other factors. So, what are the symptoms? As I told you, the prostate cancer as well as benign prostatic enlargement occludes the prostatic urethra, causes the same symptoms. Okay, so symptoms are almost same. In early stage, where a small prostate cancer is there in the prostate, it may not develop any prostate cancer because small tumors may not cause obstruction to the prostate. So early stage cancers are either diagnosed just because of PSA blood test you do in your master health checkup from the age of 50 years. And sometimes if you go to a urologist or uro-oncologist, when they do rectal examination, they can feel abnormality in the prostate. So these are the only ways to diagnose prostate cancer in an early stage. This is very important. If you diagnose prostate cancer in a very early stage, just with PSA blood test every yearly once, and your clinician examines your prostate, it is possible to detect prostate cancer in an early stage. And if you detect in early stage, 100% is possible to cure. So we should not wait for symptoms. When symptoms are there, that means that the size of the lesion is bigger, which is causing obstruction. Generally, it is in later stage prostate cancers, that is stage 3 or sometimes stage 4 prostate cancer will have these symptoms. So if you want to get detected early, don't wait for symptoms. Even without having symptoms, go to your doctor after the age of 50 years, get your PSA done, get your examination done. That is the best way to detect prostate cancer if one can develop and cure is possible. The advanced prostate cancers can produce many other symptoms, like in locally advanced or stage 3 prostate cancer, hematospermia can be there, that is blood in the semen. Retention of urine can be there, and sometimes blood can also be there in the urine. In stage 4 cancers, generally back pain will be there because prostate cancer commonly spreads to the spinal bones. So the spinal column or any vertebra. Swelling of the legs can be seen because whenever enlargement of the lymph nodes are there because of lymph nodal metastasis, that can cause obstruction to the lymphatics from the lower limb. They can present with swelling in the legs. Very rarely we have seen even these lymph nodes can cause obstruction to the ureters, and prostate itself can infiltrate the bladder and can cause obstruction to the urine flow at the where the ureters enter the bladder. It's called vesicular junction. So because of obstruction and infiltration, they can develop renal failure. So how is prostate cancer diagnosed? Am I audible? I'm not getting any response.
Yes, sir, you're audible.
Okay, okay. It's going good?
Yes, sir.
Okay, thank
Carry
you,
on.
thank you, thank you. I request all the audience to make note of any doubts or questions so that we can address all those things. So how is prostate cancer diagnosed early? That means stage 1 and stage 2. You can diagnose only by screening. You should not wait for symptoms. So why should we diagnose? As I told you, cure is possible only if we diagnose in early stage. Stage 1 and stage 2, almost close to 100% is curable. But still, after having this information, still we are diagnosing prostate cancers in stage 3 and stage 4 in India because of lack of awareness. So this talk is very important to create awareness amongst all of us. I have a couple of doctors, MS, MCH, DM doctors, without having this knowledge, when they go for master checkup or when they go for but go with any symptoms, urinary symptoms, they get diagnosed with prostate cancer. I've seen a couple of doctors presenting with stage 4 disease. Okay. So I urge all of you to go for mast cell checkup yearly once after the age of 50 years. With just PSA, you can diagnose prostate cancers early. When you compare the deaths because of prostate cancer in India and USA and Australia, if every 100 prostate cancers are diagnosed in India, because of late stage diagnosis, almost 70% are dying. 100 diagnoses, 70 are going to die eventually because they present in stage 3 or stage 4. If you compare that in Australia and Europe and America, it is around 12 to 14% because there is a very strong screening programs are there. They are aware of prostate cancer. They go for PSA testing at the age of 50 years, and if they have family history at the age of 40 years, so that they can get diagnosed. So death rates are less in America and Australia, whereas in India, it is very high because we don't follow the guidelines. We don't go for PSA checking. I don't have any symptom. Why should I go to a doctor? Unnecessarily spend money. So this attitude is very prevalent in our population. So if you go for mast cell checkup after the age of 50 years, if PSA is less than 2 to 3, generally it is normal for Indian population. In all the labs, they mention 0 to 4 is normal. 0 to 4 is not normal for younger individuals. 4 may be normal for 80 years, but the 3 PSA or 4 PSA is not normal for 50-year-old. So age specific PSA is very important. So your doctor can tell you, but generally PSA should not be more than 2 to 3, even for Indian patients, because Indian patients produce lesser PSA. So PSA is very important uh, tool or test apart from examining the prostate. So these two things, PSA and examination of the prostate, we can detect prostate cancers in an early stage. Of course, PSA should be done every yearly. If you have done PSA now, if it is normal, say 0.5, next year you should go for it. My PSA is 0.86. I do every yearly. I am 55 years of age. If PSA is abnormal or an examination, if it is suspicious, then we have to confirm that. How to confirm? We go for MRI scan of the prostate. MRI shows any abnormality called PIRATS 1, 2, 3, 4, 5 lesions. PIRATS 1 and 2 lesions are generally benign. PIRATS 3, 4, 5, the risk of having malignancy is more. So we try to do biopsy for PIRATS 3 onwards. So prostate biopsy is required to confirm the chance of having prostate cancer. It's a very simple biopsy techniques are there. Under daycare, we can do. Some people are doing even under local anesthesia, but we do under sedation because it's totally painless. So we take multiple cores from the biopsy, true cut biopsy. Generally, for 40 grams prostate, we have to take at least 12 to 14 cores. If the size of the prostate is bigger, we may have to take more cores so that sampling error should not be there. So, as I told you, if biopsy is confirmed either before or after MRI, then we know that prostate cancer is there. What is the stage of the prostate cancer? To understand that, sometimes if MRI is not done, we go for MRI, or if MRI is already done and biopsy is confirmed, we have to understand the stage of the disease by PSMA PET scan. PSMA stands for prostate specific membrane antigen PET scan. This is specific for prostate cancer, unlike FDG PET scan, which works for many other malignancies. So this is how you can understand the stage of prostate cancer on MRI. You can make out the left side, it's a T1 lesion which is confined to the prostate. T2, again, it is present in both lobes of the prostate. T3 disease, which has gone outside the prostate into seminal vesicles or outside the capsule. And T4 disease is involvement of the adjacent structures like grossly involving the bladder or infiltration of the rectum or even pelvic floor muscles. So when we detect in stage 1 and 2, it is potentially curable by surgery or sometimes with hormone therapy and radiotherapy. In locally advanced prostate cancer, cure is possible in most of the patients, but not just with surgery or radiotherapy. Sometimes we have to go for multimodality therapy. We give hormone therapy to control the disease. Then we go either for surgery or radiotherapy. There is a latest evidence to say that even in locally advanced prostate cancer, by giving hormone therapy first, then go for surgery. And if the disease comes back, you can still go for radiotherapy. This sequence, following this sequence, the cure rates can be enhanced. This is example of a PSMA PET scan where you see stage 4 disease there. All these golden yellow lesions on the bones are metastatic lesions. So prostate cancer has spread to all these bones. Generally, it has a predilection to spread to bones. So that's about prostate cancer. When coming to treatment options, generally very low risk prostate cancers are there. If 80 years old person is there, borderline elevation of the PSA. If biopsy is done, biopsy is showing very low grade tumors, generally treatment may not be required. Don't get confused with all these treatment options. Don't advocate based on these things because it is not that simple. It is highly complex. You have to discuss with your urologist or uro-oncologist. So there's a term called active surveillance where low risk prostate cancer in elderly people where the life expectancy is less, probably active surveillance is one of the options. For other stage 3, 1 to 3, where prostate cancer is present, a larger volume prostate cancer is present in the prostate, or even the Gleason score or the aggressiveness of the tumor is higher, then we have to go for surgery, that is removal of the prostate and seminal vesicle along with the lymph nodes. Generally, we do nowadays with robotic surgery. Robotic surgery is very common. The alternative to surgery is hormone therapy and radiotherapy. For stage 4 prostate cancers, these are generally incurable, but we can control this disease even if it is stage 4 for 5-6 years. Initially, we start with hormone therapy. Sometimes we go with the second line hormone therapy, chemotherapy, immunotherapy. So many options are there. Even lutetium therapy. So many options are there. Unfortunately, for stage 4, if we detect, we have to give all these treatment options. And by giving all these, still we cannot cure, and the patient will end up spending a lot of money for all these treatment options. So just to touch briefly upon robotic surgery, you all know open surgery and laparoscopic surgery. Robotic surgery is robotic assisted, laparoscopic assisted robotic surgery. Principles of laparoscopic surgery where we'll be utilizing the robot to do the surgery. It does not do surgery on its own. It's a master slave principle where we have to sit on the console. Every movement, the trained urologist or uro-oncologist will move the joysticks or actuators so that same movements will be duplicated inside the body through the robot. Why it is common, why it is so popular? Because of its preciseness and accuracy. We can see the prostate and surrounding structures with almost 10 to 40 times magnification. Blood loss is insignificant. In fact, to tell you from last 3 years, our blood transfusion rates are zero for robotic radical prostatectomy. When we used to do open surgery almost 9-10 years ago, our blood transfusion rates were 56%. Now, with the advent of robotic surgery, from last 3 years, the blood transfusion rates are zero. So, blood loss is very negligible. Because of this keyhole surgery, because of precise surgery, patient can recover fast because blood loss is not there. Smaller incisions will be there. Wound complications are less. And we can preserve the sphincter and nerves which are required for erection. And when we preserve the sphincter, the risk of urine leakage will be less and we can still protect the sexual function. So this is the prostate which is removed after doing radical prostatectomy using Da Vinci robotic system. So in this particular case, we have preserved the neurovascular bundle so that patient will have sexual function even after removal of the prostate. As you know, we have gone very close to the prostate. We have preserved the sphincter in this so that incontinence will be very less. As I told you, alternative to surgery is hormone therapy and radiotherapy. And for stage 4 prostate cancer, as I told you, hormone therapy is there, second line hormone therapy, chemotherapy, second line chemotherapy, PARP inhibitors, immunotherapy, and lutetium therapy. These are all very expensive. Once hormone therapy fails, we should go for chemotherapy. If that fails, go for PARP inhibitors. The total cost with the availability of all these drugs in India, it goes up to almost 1 crore if you're going to utilize. Despite of that, a lot of spending will be there and you're not going to cure this disease even after spending. So toxicity will be there with all these things. At the end of all these things, you may survive for 5, 6 years or 7 years, but you'll be spending this much money and you're going to suffer. So better to diagnose prostate cancer in an early stage where surgery can cure this. So how to reduce the risk? You have to follow certain guidelines, follow testing guidelines, particularly Urological Society of India, European Urology Association, and even American Urology Association recommends PSA testing for all men from the age of 50 years every yearly once. If they have any family history of cancers, as I told you, breast cancer or prostate cancer, you should start checking from the age of 40 years. So regular screening, yearly screening is very important. Know your family history to understand that. Eat a healthy and well-balanced diet. Doing regular exercise is very important. Avoid smoking and tobacco and even alcohol. These things can prevent to some extent, but even if you are a teetotaler, your chances of getting prostate cancer is there. So don't, many patients will come, I'm a teetotaler, how can I get cancer? It's a genetic disease, anybody can get it. So these are the recommendations from USI, that is Urological Society of India, American Urology Association, and European Urology Association. Do your PSA, which is a simple blood test, which costs about 600, 700 rupees, and prostate examination by digital rectal examination for all men after the age of 50 years. And if family history is there, from the age of 40 years, you have to start checking this. Thank you. I'm happy to take up any questions.
Thank you so much, sir, for your insightful presentation. Now let us see what are the questions that have come from your audience.
Yeah.
And I would
Shall I stop sharing?
Yes, sir, sure.
Okay. Yeah.
I would request everyone who are there with us, kindly put your questions in the chat and I will be able to read them out to sir. Meanwhile, we have received a few questions which I would like to read out. Sir, how has the role of robotic assisted surgery evolved in the management of localized prostate cancer and what advantage does it offer over conventional approaches?
So as I told you, open surgery, you open and do the surgery with a manually you do the surgery. The blood loss is more. Longer incision will be there. So recovery takes more time. And in robotic surgery, small incisions are there, very precise movements are there with such a magnification from 10 to 40 times. Blood loss is very less, wound complications are less. You can preserve the required structures, that is, sphincter can be preserved better, and you can also save the nerves which are required for erections. So we can prevent sexual dysfunction by preserving the nerves. We can prevent incontinence of the urine by preserving the sphincter complex. And wound complications are, as I told you, are very less. Recovery is faster because of less blood loss. So they can go back to work early. These are the advantages of robotic surgery over open surgery. And even for that matter, even laparoscopic surgery. When we compare laparoscopic surgery versus robotic surgery outcomes are far superior to even laparoscopic surgery. Whereas robotic surgery comes at a cost because of the technology. The machine cost would be around 6 to 10 crores or 12 crores. It depends on the type of systems you use. And even in India, almost close to 160, 180 robotic systems are there. In major centers, radical prostatectomy is done through robotic means only. I hope I answered that question. If you have any further questions, please ask me. I'm happy to answer.
Right, so another query is from Dr. Saravanan, who wants to know what is the rising use of multiparametric MRI and PSMA PET CT, and how has the diagnostic landscape for prostate cancer changed in recent years?
Yeah. So earlier we used to do biopsy based on PSA. Now we always go for MRI scan before doing biopsy. So MRI will give us a picture where all the abnormal lesions are there, and we can take biopsy from those particular lesions under the ultrasound guidance. It's called sometimes transrectal ultrasound guided fusion biopsy, where MRI shows some lesions. We can map out those lesions on the ultrasound and we can take targeted biopsy from that so that the diagnostic yield will be higher. We are not going to miss the prostate cancer. So whenever we do biopsy, sometimes we can miss prostate cancer. Even prostate cancer is there, we may not take biopsy from that particular site. So by combining MRI and fusing those images on ultrasound, we can take precise biopsy so that the diagnostic yield will be very high. And when it comes to even PSMA PET scan, all this while it is for diagnosing the stage of the prostate cancer. Once we confirm to know the stage of the prostate cancer, we used to do, and PSMA scan is coming up in a big way for even diagnosis. Both MRI and PSMA PET scans are coming up for the diagnostic as a diagnostic tool even before biopsy. But it is not standard of care to do PSMA PET scan for diagnosis. It's only for staging evaluation we are doing at this point of time.
Thank you so much, sir, for answering the query. This question is from Dr. Arvind Sharma, sir. He wants to know, in terms of active surveillance, what criteria do you consider essential to decide when to intervene versus continue observation?
Yeah, it's a very interesting question. I appreciate you for asking this question. Say, for example, for active surveillance, you can practice active surveillance for all age groups, but generally for elderly individuals, when the PSA is less than 10, and when you do biopsy, if you take 12 cores, 12 pieces from the prostate, the number of cores, positive cores should be less than 2, 2 or less than 2. If 3 or 4 cores are positive, it's a high volume disease. And when out of 12 to 14 cores, if only 2 or less than 2 cores are positive, that means it's a small volume disease. And in that, the length of the core, normally the core length will be around 20 to 22 millimeters. In that, it should be less than 50%. So generally or basically, if it is a very low risk prostate cancer, low PSA, low stage tumors, we call it as very low risk or low risk tumors, where these tumors may not kill the patient. These are generally slow growing. In such cases, we don't go for any treatment with either surgery or radiotherapy. We just observe, do the PSA again, do MRI scan yearly. In case if this is progressing, size of the lesion on MRI is progressing, increasing, or PSA is increasing, PSA crossed more than 10, or when you repeat the biopsy, earlier only 2 cores were positive, now 4 cores are positive. That means that disease is progressing. In such cases, you shift them from active surveillance to active treatment. The active treatment could be either surgery or hormone therapy, radiotherapy. So between hormone therapy, radiotherapy, and surgery, you have to discuss with your doctor which is convenient for you. Accordingly, you have to decide. Hope I answered that question. It's a very interesting question. Thank you for asking this question.
Thank you, Dr. Sharma. Your question is really appreciated. Next question is from Dr. Nalini. She wants to know, what are the current challenges in managing castration-resistant prostate cancer?
Yeah, I did not address that. So castration-resistant prostate cancer means it is generally stage 4 cancers. Once you give hormone therapy, primary hormone therapy, where you reduce the testosterone levels to less than 20 nanograms, despite of reducing the testosterone, despite of doing either orchiectomy or giving leupride injection or LHRH injections, if the disease is progressing, that is called castration-resistant prostate cancer, where you have done castration, but despite of that, initial control will be there and it will escape that control. That's called castrate-resistant prostate cancer. There are a couple of options are there. Second-line hormonal agents are there. It's also called ARPI, androgen receptor pathway inhibitors are there. We have chemotherapy. We have lutetium therapy is there. Even PARP inhibitors are there. So we are going to utilize all these things in a particular sequence. We have to see patient general condition, toxicity profile of all these treatment options, affordability. We put all these things, we discuss with the patient what is required after giving ADT or androgen deprivation therapy. In CRPC or castrate-resistant prostate cancer, we have to suppress the androgens. Androgen deprivation therapy should be given. Along with that, we can add any one of these treatment options.
Thank you so much. So we will take one last query. Doctors, kindly put your questions, and as we are running out of time, we'll take one last query and then we'll close the session. Okay. This question is from Dr. Rajesh. How do you approach the balance between oncological control and preserving quality of life, especially urine and sexual function in prostate cancer patients?
Yeah, very good question. So, as I told you, uh, when you have to do a surgery, the better to choose robotic surgery. That's number one. The technology is very important. So with the technology, we can preserve the sphincter, we can preserve the neurovascular bundle, which are required for continence and sexual function. The second is experience of the surgeon. So experience makes a lot of difference. If the surgeon has done, say, more than 500 or 1000 robotic radical prostatectomies, the results are generally better. So choose a better surgeon, choose a better technology. With both, probably you can avoid or reduce the risk of incontinence and sexual functions dysfunction.
Thank you so much, sir, for answering all the questions like really nicely. And before wrapping up, I would like to thank you for your valuable time and insightful contribution to this webinar. And this is to all the participants. I hope this webinar has provided valuable takeaways that you can apply moving forward. Thank you all for your active participation. Thank you so much, sir, once again for putting your effort and your time. Thank you, sir. Thank you so
Thank
much.
you, madam.
It's a
Thank you.
pleasure.
Thank you.